Hello everyone and welcome to our module on cyanotic congenital heart disease. Let's start by talking about cyanosis. Cyanosis is a bluish discoloration of the skin and it can be divided into two types, central cyanosis and peripheral cyanosis. Central cyanosis is the type seen in babies with certain forms of congenital heart disease. This can occur when the cardiac output is normal and blood is flowing to the body, however that blood is not carrying enough oxygen. This type of cyanosis can be evident in the lips, in the nail beds, you can see it in the conjunctiva, and the extremities will be warm because they are being perfused with warm blood. The blood just doesn't have enough oxygen in it. In contrast, peripheral cyanosis is what you can see when there is low blood flow in the setting of severe heart failure. In this situation, the decreased oxygen is only evident in the extremities, so these patients will have cold extremities because there's not enough blood flow, and in addition, the fingertips and toes can be blue because those parts of the body that are far away from the heart are not getting enough blood flow. In this video, we're going to talk about congenital heart disease that causes what's known as blue babies. So these are babies that develop central cyanosis early in life. This occurs because blood is not going through the lungs due to some form of congenital heart disease. There are 5 classic causes of a blue baby. They're listed on the screen here. They all start with T, so they're often called the terrible T's. So we'll talk about all 5 of these causes, plus a few other causes of cyanosis that can occur in babies. Let's start by talking about tetralogy of Fallot, which is the classic congenital heart disorder that causes cyanosis in a baby. Tetralogy of Fallot gets its name because it's a constellation of 4 abnormalities. First of all, there is a ventricular septal defect, or VSD. Secondly, there is rightward deviation of the aortic valve. This is called an overriding aorta. Third is subpulmonary stenosis, and fourth is right ventricular hypertrophy. And you can see all 4 of these abnormalities in the cartoon on the screen here. This structure here is the aorta and the aortic valve, and it is shifted to the right, and this causes it to override the ventricular septum and this VSD right here. That's called an overriding aorta. This is the right ventricle here, and you can see that the walls of the right ventricle are very thick. That's right ventricular hypertrophy, and this is the pulmonic valve and the outflow of the right ventricle, and that is abnormal and stenotic, and that is subpulmonary stenosis. Even though there are 4 abnormalities in tetralogy of Fallot, they are all caused by a single abnormal structure called the infundibulum, which is also sometimes called the conus arteriosus. In fact, some people like to call this disorder monology of Fallot because it's all due to one abnormal structure, the infundibulum. In Latin, the word infundibulum means funnel, so this structure is a funnel that leads out of the right ventricle toward the pulmonic valve. It develops from the embryologic bulbus cordis, which is shown at the bottom of the screen here in the heart tube, and it is a smooth muscular funnel-like structure that leads out of the right ventricle towards the pulmonary artery. The entire problem in tetralogy of Fallot is caused by a displaced infundibulum which moves towards the right ventricle. If you look at this cartoon on the screen here, this is the infundibulum here, and it's been moved this direction toward the right ventricle. That drags the aorta with it and causes the aorta to override the right ventricle. It also creates a gap through which blood can flow, and that's what causes the VSD. It's usually a very large, non-restrictive VSD that allows lots of blood to flow from the right side of the heart to the left. Not only is the infundibulum the cause of the overriding aorta and the VSD, it's also the cause of the subpulmonary stenosis. The type of stenosis seen in tetralogy of Fallot is called infundibular stenosis. The infundibulum is abnormally formed and therefore it restricts the flow out of the right ventricle into the pulmonary artery. This is described as subpulmonary stenosis or RV outflow tract obstruction. There is usually an abnormal pulmonary valve in tetralogy of Fallot, but it's rarely the main cause of obstruction. The real cause of the outflow obstruction is the infundibulum. And because there's a resistance to outflow from the left ventricle, in response the right ventricle hypertrophies, and therefore the infundibulum is responsible for all 4 elements of tetralogy of Fallot: the overriding aorta, the VSD, the infundibular stenosis, and the RVH. To understand the physiology of tetralogy of Fallot and why babies with this condition become cyanotic, you must appreciate that the infundibular stenosis causes a high resistance to flow from the right ventricle to the pulmonary artery. This is called RV outflow pulmonic stenosis. And because it's very difficult for blood to go from the right ventricle into the pulmonary artery due to this stenosis, blood instead will go across the VSD to the left ventricle. This means that deoxygenated blood that is not crossed through the lungs will be going through the systemic circulation, and this is what makes the baby cyanotic. And a very high yield point for you to appreciate is that the severity of flow obstruction determines the symptoms. Babies that have a variant of tetralogy of Fallot with severe RV outflow obstruction will have severe cyanosis and they often die from the condition. Occasionally, babies are born with very mild obstruction. They have less shunting to the left side of the heart and more blood flow through the lungs, and these children often have very little cyanosis. They're sometimes described as pink tets. Because there is poor blood flow from the right ventricle to the lungs, some left to right shunts are beneficial. Any left to right shunt that brings blood back to the pulmonary artery will divert blood flow to the lungs and improve oxygenation. So for example, babies with tetralogy of Fallot who have a patent ductus arteriosus are helped greatly by that shunt because it delivers blood flow to the lungs and bypasses the infundibular stenosis. And in fact, we'll talk later about how medicines are sometimes administered to maintain patency of the ductus arteriosus in babies with tetralogy of Fallot. In addition, some babies develop collateral arteries called aorticopulmonary collateral arteries, and these are helpful. And then finally, surgical shunts are sometimes placed in order to deliver blood to the lungs from the aorta. The classic cardiac oscillatory findings in tetralogy of Fallot are a systolic ejection murmur and a single S2. A systolic ejection murmur is a crescendo-decrescendo murmur, like what I've shown on the screen here. It occurs between S1 and S2. This is caused by the RV outflow and pulmonic stenosis, and it's heard best at the pulmonary listening point at the left sternal border. The single S2 occurs because S2 is the result of closure of the aortic and pulmonic valves. And in tetralogy of Fallot, there is a diseased pulmonic valve and poor flow through the RV outflow tract, and for this reason, there is no sound from the pulmonic valve. Therefore, you get a single S2. And you might be wondering if there should be a VSD murmur, which is a holosystolic murmur, but this is not typically heard, and that's because the VSDs in tetralogy of Fallot are very large, and therefore they do not generate a murmur. The classic chest x-ray finding in tetralogy of Fallot is the presence of a boot-shaped heart, like what I've shown on the screen here. You can see it looks like a boot. The reason it is boot-shaped is because the apex is abnormally positioned and the right ventricle is hypertrophied. Some other features of tetralogy of Fallot you should understand. Squatting often improves symptoms in children who have this condition. The reason this helps is because when children squat, they kink their femoral arteries. This increases the afterload and the peripheral resistance. These are the forces that resist flow out of the left ventricle. This will make it harder for blood to flow out of the left ventricle, and the pressure will rise in the aorta and left ventricle. This will result in less blood being shunted across the VSD from the right ventricle to the LV. As a result, more blood will go to the lungs and the child will feel better. In addition, babies and children with tetralogy of Fallot often suffer from something known as TET spells. This is sudden severe cyanosis that occurs when the child gets agitated. This is caused by worsening of the RVOT obstruction. Remember, all the symptoms of this disorder are related to the degree of RVOT obstruction. So when it gets worse, the child will get sicker. This can potentially be a life-threatening complication of this disorder. Children are treated with oxygen. The knees are often pressed to the chest. This is just like squatting. It's designed to increase the afterload and drive blood flow through the lungs. And then finally, beta blockers like propranolol are sometimes helpful because they have been shown to decrease the degree of RVOT obstruction. All right, moving on, let's talk about the congenital heart condition truncus arteriosus. In the video on cardiac embryology, I talk about the truncus arteriosus. It's a normal structure in the embryo. It's part of the primitive heart tube, and under normal conditions, it divides into the aorta and pulmonary artery. In the congenital heart condition truncus arteriosus, the truncus arteriosus persists, and therefore the outflow of both the left and right ventricles has a common arterial trunk. This results in mixing of blood and poor delivery of blood to the lungs, and therefore there is cyanosis. One of the most important things for you to know about this for the Step 1 exam is that it is caused by a failure of neural crest cells to drive formation of the aorticopulmonary septum. This is what they are most likely to ask you about on the Step 1 exam. In addition, it often has a VSD, and that creates a situation like what is shown in this picture here, where the right and left ventricles are mixing blood through the VSD and pumping a mixture of blood out into the aorta and pulmonary artery. This results in poor oxygenation of blood and cyanosis in a baby. Next, we'll talk about transposition of the great vessels, or it is sometimes also called transposition of the great arteries. In this condition, the aorta and pulmonary artery are switched so that the right ventricle pumps to the aorta and the left ventricle to the pulmonary arteries. This is depicted in this picture on the slide here. We've got the right ventricle pumping blood into the aorta, and on the left side, we have the left ventricle pumping blood into the pulmonary artery. The most important thing for you to know about this condition for Step 1 of the boards is the relative position of the aorta to the pulmonary artery. So in a normal heart, as is depicted on the screen here, the aorta is posterior and to the right of the pulmonary artery. You'll notice in this picture that the pulmonary artery goes over the top of the aorta. This makes the aorta posterior and slightly rightward compared to the pulmonary artery. In detransposition of the great vessels, which is the most common type, the aorta forms anterior and rightward of the pulmonary artery. This is what you want to know, that the aorta is anterior instead of posterior to the pulmonary artery. As a result of this, the aorta arises from the right ventricle, as I said before, and the pulmonary artery from the left ventricle. And this is depicted in this cartoon on the screen here. You can see that the right ventricle here is pumping into the aorta, which is now slightly anterior compared to the pulmonary artery. It remains slightly rightward, but now it is anterior to the pulmonary artery. In detransposition of the great vessels, what you have is blood from the right ventricle that goes to the aorta instead of the pulmonary artery. From there, the blood flow goes to the body, and then it comes back to the right side of the heart, going to the right atrium and the right ventricle again. On the left side of the body, you have a separate circuit where blood flows from the left ventricle to the pulmonary artery, then it goes through the lungs and comes back to the left side of the heart, going to the left atrium and left ventricle. This means you have two completely separate circuits, and thus this is not compatible with life unless there is a shunt present to allow mixing of blood so that some of the oxygenated blood from the lungs can get to the body. So babies with transposition of the great vessels need to have either a PDA or VSD present to allow mixing of blood. At the bottom of the screen, I've shown the two circuits. So on the right side of the heart, you have a circuit that does not go through the lungs. On the left side of the heart, you have a circuit where the blood does not go through the body. So a VSD would allow the right ventricular blood to mix with the left ventricular blood. A PDA would allow the pulmonary artery blood to mix with the aortic blood, and you need one of these shunts present for this to be compatible with life. There is a more rare variant of transposition of the great arteries called LTGA. In this condition, there's a double switch. Not only are the aorta and pulmonary arteries switched, as we described in detransposition, but in addition, the left and right ventricles are switched. This is sometimes called congenitally corrected TGA because you do not have two separate circuits. The way the blood flows in LTGA is very confusing, but I'll try to walk you through it. Basically, the venous blood drains into the right atrium as it should, but from there it goes to the left ventricle and then to the pulmonary artery and the lungs. This is very unusual and different from the normal situation. Blood from the lungs drains into the pulmonary veins, which it should do, and then to the left atrium, but from the left atrium it goes to the right ventricle and then to the aorta. So the bottom line here is that you have two separate circuits, but they are not separated as they are in DTGA. And the reason they're not separated is because you have the wrong connections, the right ventricle to the aorta and the left ventricle to the PA. And all this circuitry can get very confusing, but the key thing that you want to remember about LTGA is that the major clinical problem is that eventually the right ventricle will fail. In LTGA, the right ventricle is hooked up to the aorta, and the right ventricle cannot tolerate that systemic load. So children with this condition, if it's not surgically repaired, eventually die of right heart failure. Babies born to mothers who have diabetes are at increased risk of a number of congenital anomalies, and it's common for them to have congenital heart defects. And among the various congenital heart defects, transposition is one of the most common. They can also have all of these defects I've shown on the screen here. What you want to remember for your boards is that this condition, transposition, is associated with maternal diabetes. Now let's talk about tricuspid atresia. In this condition, there is abnormal formation of the AV valves from the endocardial cushions, and what this leads to is a situation where there is no tricuspid valve in the heart, and therefore blood cannot flow from the right atrium to the right ventricle. Since blood cannot travel directly from the right atrium to the right ventricle and then to the lungs, the only way tricuspid atresia is compatible with life is if there is a right to left shunt to allow blood flow to go to the left side of the heart, and then another left to right shunt to allow blood to come back to the right ventricle and go to the lungs. So all cases of tricuspid atresia have an atrial septal defect. This allows blood to flow from the right atrium to the left atrium since it cannot go from the right atrium to the right ventricle. In addition, all cases have a left to right shunt that allows blood to flow to the lungs. This can be a left ventricle to right ventricle shunt via a VSD, or it can be an aorta to pulmonary artery shunt via a PDA. But the important point here that you want to remember, especially for step one, is that there must be a right to left shunt and also a left to right shunt to allow the blood to travel in a circuitous path from the right atrium to the right ventricle, because it cannot go directly from the right atrium to the right ventricle through the tricuspid valve. Now let's talk about total anomalous pulmonary venous return. In the normal heart, as you know, the pulmonary veins drain blood from the lungs to the left atrium. In anomalous pulmonary venous return, the pulmonary veins instead drain blood to the venous system. There are a number of anatomic variants. One of the most common is where the pulmonary veins drain blood from the lungs to the innominate or brachiocephalic veins, and from there the blood goes to the SVC. Some of the other variants are where the lungs drain through the pulmonary veins to the coronary sinus, and sometimes the lungs even drain to the portal vein. But the point here is that instead of the blood going to the left side of the heart, it drains back to the right side of the heart. And shown in this cartoon on the screen here is the variant where the blood drains to the brachiocephalic veins and then to the SVC. So we've got blood that should go to the left atrium, but instead it goes up to the innominate vein here and travels to the SVC and back to the right side of the heart. That is one of the variants of anomalous pulmonary venous return. So the path that blood is going to take in this condition is from the right ventricle to the lungs, then to the pulmonary veins, and then back to the right side of the heart, to the right atrium and the right ventricle. This is going to lead to dilation of the right atrium and the right ventricle, and when we image the heart, we often can't see all the venous structures and the path that the blood takes. So one of the things that makes you suspicious of pulmonary venous return is when you see enlarged structures on the right side of the heart, like the right atrium and the right ventricle. Now, for this condition to be compatible with life, there must be some right to left shunt that allows blood to get over to the left side of the heart. Usually there is an ASD, although sometimes there is a PDA. This allows mixed blood, which contains oxygenated and deoxygenated blood, to go to the body. That blood will have a low oxygen content, and therefore this condition leads to cyanosis in a baby. I'll finish this module with a couple of conditions that are not part of the 5 terrible T's, but that can potentially cause cyanosis in a newborn baby. One of them is called Ebstein's anomaly. This is a condition in which there is apical displacement of the tricuspid valve, which leads to a very small right ventricle. If you look at the cartoon on the screen here, on the left is a normal heart, and the tricuspid valve is located about midway between the top and bottom of the heart. In Ebstein's anomaly, the tricuspid valve is displaced towards the apex of the heart. This makes for a very small right ventricle and a very large right atrium. What happens in this condition is there is so-called atrialization of right ventricular tissue, meaning that the atria begins to encompass parts of what should be the right ventricle. The major problem in this disorder hemodynamically is that there is usually severe tricuspid regurgitation, and this can lead to right heart failure. If there is a right to left shunt, like an ASD, the high pressures in the right atrium from tricuspid regurgitation can lead to shunting of deoxygenated blood from the right side of the heart to the left side of the heart, and therefore Ebstein's anomaly can lead to cyanosis. In addition, a very high yield fact for you to know about Ebstein's anomaly for your boards is that it is commonly associated with the Wolff-Parkinson-White syndrome. Many children born with this condition have electrical bypass tracts present. This leads to arrhythmias and the presence of a delta wave on the EKG as shown at the bottom of the screen, and I have a separate video on the WPW syndrome. Lithium is a drug that is used to treat a number of psychiatric disorders, and it is dangerous to the baby if mothers take this drug when they're pregnant. Lithium is a teratogen. It completely equilibrates across the placenta, and most of its teratogenic effects involve the heart, and for reasons that are incompletely understood, Ebstein's anomaly is the most common cardiac malformation that occurs in mothers who take lithium. This is very high yield for you to know for step 1 of your boards. The final condition I'll discuss is pulmonary atresia. As the name implies, in this condition there is failure of the pulmonic valve orifice to develop. As a result, there is no conduit to allow blood to flow from the right ventricle to the lungs. Now in utero, this is not a problem because, as you know, blood bypasses the lungs in utero. This is part of normal development. However, at birth, the baby can get very sick because there is no blood flow to the lungs through the pulmonic valve. Remember that one of the major hemodynamic changes that is supposed to occur at birth is that the pulmonary vascular resistance should fall, but this doesn't happen in pulmonary atresia because there is no conduit to conduct blood from the right ventricle to the lungs. This condition often coexists with a VSD, which allows blood to exit the right ventricle and go to the left ventricle, and this is similar to a severe form of tetralogy of Fallot. Remember, in tetralogy of Fallot, there is obstruction to outflow from the right ventricle. In this situation, we have no outflow from the right ventricle, so if there's a VSD present, you will get physiology very similar to tetralogy of Fallot. And for a baby to survive with this condition, they need the ductus arteriosus to stay open. That allows blood to flow into the lungs, bypassing the atretic pulmonic valve orifice. And for that reason, the drug eprostadil is given to babies with this condition to keep the ductus arteriosus open. Here are some cartoons of pulmonary atresia. On the left side is a heart that has no VSD. So in this situation, the right ventricle has nowhere to pump blood to. It can't pump it into the pulmonic valve, and it can't pump it to the left ventricle because there is no VSD. The left ventricle does all the work circulating blood. It pumps blood into the aorta, and then some of that goes through the PDA and gets to the lungs. On the right side of the screen is a heart which has a VSD. In this case, the right ventricle can pump blood to the left ventricle can pump it to the aorta, and then the PDA will deliver blood to the lungs. So let's talk about a prostadil. In the video on cardiac embryology, I talked about how prostaglandin E2 is produced by the placenta to keep the ductus arteriosus open in utero. Alprostadil is prostaglandin E1, so it can be administered as therapy to maintain patency of the ductus arteriosus. And the major effect of this drug that you want to remember when thinking about what it does to babies with congenital heart disease is that it delivers blood to the lungs. It keeps a connection open between the aorta and pulmonary artery. This delivers blood to the lungs when there's obstruction to flow from the right ventricle to the lungs. So this drug is useful anytime there's very poor blood flow from the right ventricle to the pulmonary artery. And the two key situations where this is the case are tetralogy of flow, where there's obstruction from the right ventricle to the pulmonary artery, and pulmonary atresia, where there's no conduit to conduct blood from the right ventricle to the lungs. I'll finish with this slide and mention a term that you may read about in your textbooks and board review books, and that term is conotruncal heart defects. This term is used to refer to a number of congenital heart disorders where there is an outflow tract problem. The trunk in the word conotruncal means the truncus arteriosus, and the cone in the word conotruncal means the conus arteriosus, and these two structures form the outflow of the right and left ventricles. So conditions that are considered examples of conotruncal heart defects are tetralogy of Fallot, truncus arteriosus, and transposition of the great arteries. In all three of these conditions, there are problems with the outflow from the right and left ventricles. And the classic condition in which conotruncal heart defects occur are the 22q deletion syndromes. One of these is DeGeorge syndrome, which is also called thymic aplasia. I discuss this in the genetics section. I also discuss it in the immunodeficiency video in the immunology section, but babies born with these genetic disorders have immunodeficiency and hypocalcemia, and they also classically develop any or a number of the conotruncal congenital heart anomalies. And that concludes our video on cyanotic congenital heart disease.